Good morning. It's wonderful to have all of you with us virtually. I am absolutely thrilled to have our keynote speaker with us, Don Crane, who's the president and CEO of America's Physician Groups, APG, which is really the leading organization leading change toward value among physician groups in the United States. Don has been a leader for many years. He is an incredible person to get to know, and he knows everything. No pressure, Don, but now I'm going to turn everything over to you. He has a wonderful presentation for us on the movement into value. So please enjoy. I will return at the end and we'll have a little bit of a dialogue. So welcome, Don Crane. We're thrilled to have you and the floor is yours.
Thank you very, very much, Mark. It's a pleasure to do this. I've enjoyed your kind introduction, stock full of humor though it was. And I think it's a second or perhaps third time I've had a chance to talk to this audience, or mostly this audience. So it's a real honor to do that very thing. So let me jump into it. So look at this interesting title, Value Movement, Fierce New Debate on Direction. So this is indeed an apt, I think, title for a kind of an internecine fight that's going on. A fight is probably a hyperbole, but nonetheless a debate going on within the value movement. I'll get more into it in a minute. But my hope also is that it will touch on so many other points within the value movement that it'll serve as sort of, I think, good background and education on the movement more generally and how it's impacting you guys and my members. So with that, let me get started. Here's an overview. I will quickly walk through an introduction and brag a little bit about APG. I will next talk about this debate and who's involved. I will then talk a bit about why it is important, because I think it is very important, both in terms of its potential, but also in that it highlights that these are knotty issues and it isn't perfectly clear on what directions are always best, and for there to be some diversity of opinion is not all that shocking. I will next do my best to summarize what the heck this debate is all about so that you know what we're talking about. Then, as to the proponents and protagonists of this debate, I will talk about what they got right and then what they got wrong, and then I will talk a little bit about consequences. So with that, let me go ahead and jump into it, reminding this audience as to who I am and we are. So I'm the CEO of America's Physician Groups. There is our audacious tagline, taking responsibility for America's health, not really a reflection of our size, but an expression really of our payment model, which makes us accountable for cost, total cost of care, and our allegiance to performance measurement, whether it's STARS program or pay for performance program or the like, which makes us accountable for quality. And the two together make us responsible for health, basically population health. And that is who we are. We are in something on the order of 44 states now. I think we're up to 335 physician organizations that employ or contract with 170,000 physicians that in turn take care of about 90 million patients. So that is a lot. The interesting statistic for purposes of this presentation today in particular, not reflected on the screen, is that our members presently treat approximately 1/4 of all of the seniors in Medicare Advantage across the country. So that's a big number, of course, but it also kind of puts us in the stratosphere of United and Aetna. Though different, indeed they are plans and we are groups, one can see that our interest in this subject is, every bit as great as the large carriers involved. Finally, you see the words on the bottom right corner, capitation is our preferred payment model. That is indeed true, but it is also true that our members are participating in risk-based models across the entire spectrum of risk. Okay, so on the one end, it's shared savings and downside shared risk and professional risk and global risk, and capitation is perhaps this destination that we are after. It's the end state, it's preferred and desired. So that is our both our present reality for many of our members, but the goal of all of our members. So that is who we are. And of course, that sheds lights on why I say the things I do here in today's talk. So an intra-family debate, what the heck am I talking about? So Don Berwick, former head of CMS, and Rick Gilfillan, former head of CMMI, each of them occupying those posts right at the point of the adoption of the Affordable Care Act, when accountable care was really getting its start, at least as a Medicare program. I think Don Berwick has been thought of by some as sort of the father of ACOs. So these two excellent gentlemen, friends of APG, personally friends of mine, are engaged basically in an advocacy campaign that would do a number of things that I will speak to a minute in our summary, some of which we agree with and some of which we oppose. But it does, this title, take the appearance of it's in a personal sort of spat, and it is not that. These are legitimate issues to be discussed. These gentlemen are entirely well-intended, though I think misguided on a fair number of the points they are making. They started this campaign a number of months ago, I think perhaps 5 or 6 months ago, with their sort of now famous 66-page PowerPoint deck. They visited with the top representatives of HHS and CMS and CMMI and the House of Representatives and the Senate. Indeed, I think they were able to get a fair number of House members, a handful, to write a letter to Javier Becerra, urging them to adopt the recommendations that they were advancing. They have most recently authored 2 blogs, a part 1 and a part 2, that appeared in Health Affairs, about 2 weeks, 3, 4 weeks ago, maybe, if that. And I commend these blogs to your reading. I mean, I will do my best to summarize them, but you should read them. They're brilliantly written, in my personal opinion, but with a lot of misguided, I think, recommendations. And that's why we've got this intra-family debate going on. So why is this important? Well, again, as I say, there's a mix of good and bad recommendations. Many of the recommendations we would agree with, but a few we would not. It is important because this advocacy is gaining traction. We frankly think that it would impair, if not cause significant damage to Medicare Advantage, which we regard as a very good program generally, but more specifically, probably the single best example of coordinated, integrated, capitated care extant across the country right now. So anything that damages MA is going to grab our attention. And of course, it talks a lot about HCC coding, which we'll get to in a minute. What's also important about it, and particularly for this audience, many of you are so steeped in IT and data analytics and so on, is that it forces a reexamination of some of the basics, like what program is best for our future purposes, what programs will best advance our effort to address health disparities and social determinants of health. It's really caused a lot of us to think harder about really which of these models is best and so forth. So it is important, we believe, for all of those reasons, and I hope you'll agree with me as I go through it. So summary of Assertions. Again, we've seen their deck, or decks plural, a couple of versions, but it's essentially the same thing. And we've, of course, read their Medicare blogs, and I've talked with them. And I will tell you, speaking with them later this afternoon, when they are going to be presenting to my board tomorrow. So clearly our relationship is good enough to, debate these things. So here, by way of summary, are the following. So regarding Medicare Advantage, the principal kind of complaint is that Medicare Advantage is overpaid as compared to traditional Medicare. So forgive me for the abbreviations. MA is pretty well known as Medicare Advantage. Traditional Medicare isn't often referred to as TM, but I do so here. So there is the overpayment question, a much debated, hotly contested subject. Very important, of course, because statute does indeed call for basically parity between the 2 programs, and that MA not be overpaid. And so if it is being overpaid, that's an important thing. They have dubbed basically what is going on the Medicare Gold Rush. Not exactly a flattering title, but that is what they are referring to the dynamics underlying Medicare Advantage and risk adjustment and HCC coding. They allege that the health plans and physician groups, my members, and physicians generally everywhere have formed a kind of a coding machine, then are engaged basically in what are known as risk coding games, as they call them, all but with an eye to elevate the acuity level of a population, which in turn increases the revenue to the plans and the groups, thus causing Medicare Advantage to be quote unquote overpaid, paid more than traditional Medicare. So that is the gist of their assertions with respect to Medicare Advantage. Of course, that's very, very important to us. Next, we have, as you may recall, presently pending a number of pilots in CMMI. Of course, there's quite a large number of alternative payment models, APMs, but there is also a pilot at work right now we think of as basically ACO's version sort of 3.0, maybe the most sophisticated form of ACO, a model that we argued for and successfully sort of obtained. It's sort of on ice or hold now as they have attacked it with considerable success. So what I'm referring to, there are these professional risk and global risk models, two of them. They are pilots. The first cohort of participants slipped out of the door basically however many months ago, and those pilots are underway. But the second cohort has been frozen. So it's on hold. Basically, I think as a result of their allegations and their advocacy. Their chief complaint with respect to these pilots is that they have invited the involvement of health plans, and they think that health plans should have no role within these pilots. They're sort of connecting the dots now. Their allegations are that the involvement of the health plans will invite into these programs, traditional Medicare programs as they are, the practices, the improper practices of health plans used in Medicare Advantage. So the health plans are allowed into the program, they're Trojan horses, they bring with them their upcoding practices learned in Medicare Advantage. They see that as anathema, and they think that the pilot should be stopped, redesigned, and that health plans should be prohibited. There again, an interesting mix of good and bad, but you can see that underlying their allegations with respect to MA and their allegations with respect to these capitated models is the allegation that there is risk coding games, improper upcoding, as it were, and we'll talk more about that. So I think that's a fair summary of the things they say. Now, if you look at their deck, though, there are other things they speak about, their recommendations regarding a public option being very, very capitated, a good idea. So, but this is the guts of it. And so this is where I think I'm going to focus my comments. So moving on. Now, let's see, summary assertion. Now, here are their recommendations, and I've already spoken to these a little bit thus far. So we know what the allegations are on MA upcoding. So here's what they recommend for MA. Freeze the current acuity level as seen by CMS based on prior coding that has gone on, but freeze it so it can't creep higher. Next, eliminate HCC coding within 2 years. Replace it with a new risk adjustment system, one that wouldn't involve physician recording of acuity, and eliminate percentage of premium contracts. So let me unpack that just a little bit. So what is HCC coding? So these are the codes, the ICD and ICD-10 codes used by physicians within the HCC system to reflect the acuity, the illness, the sickness, and so forth of seniors in MA. We regard it as entirely necessary. Of course, is used to adjust compensation, vary compensation levels to the sickness, high or low, of a given population. So the amount paid to health plans and thus to physician groups is fair. So it makes sense to tailor payment to acuity And that's sort of one of the central purposes of HCC coding, okay? But the other thing it does, I'll elaborate on in a minute, is it enables us to basically conduct care management, both for individuals and for populations. And let me get to that in a second. But indeed, it would be earth-shattering if they were to eliminate HCC coding within 2 years. Not that we would be inalterably opposed to it if they had a better system. We're not aware of a better system at the moment. And so this clearly attracts our attention. Also, being accused of wrongdoing isn't really a warm and fuzzy feeling. They suggest implementing a new risk adjustment system, fine, but not involving physician reporting and engagement is a bad idea. Physicians and physician groups need to know who their patients are. They need to know who the diabetics are, who the hypertensives are, who has Alzheimer, who is acutely ill, who is only moderately ill. That knowledge allows physician groups to allocate resource and implement programs to specifically address those patients. So I'll elaborate a little bit more on that in a minute. Finally, the health plans, not always, but frequently, particularly in California, pay physician groups to provide the care based on a percentage of premium, also known as percentage of premium contracts, right? There are other ways to pay physicians and physician groups, but this method is favored. It creates collaboration between health plans and physician groups, previously thought to be silos. It makes those silos closer and more permeable, and there's more collaboration. And so their recommendation is to eliminate those. And so that method of payment, high, medium, or low, whatever it may be, has certainly caught our attention. Next recommendation with respect to the professional and global risk pilots, halt them, as I've said, and then overhaul the rules to prohibit health plans. And I'll comment on that in a minute, good or bad. So that's approximately a summary of their recommendations. Moving forward, so what they got right. Well, first off, there are abusers of the HCC coding system. So in traditional Medicare, there are abusers. So there are physicians that bill for services that were rendered or bill too much, et cetera, and there's in fact criminal prosecutions of them. And there are indeed some of those wrongdoers in prison today. We've long known that fraud and abuse in traditional Medicare is a big problem, measured both in terms of sort of behavior, but also measured in terms of the dollars. So as we shift our gaze to traditional to Medicare Advantage, the payment is via capitation, and the sort of bill that physicians submit, if I can loosely call it that, is the HCC coding by which they reflect the acuity, the level of sickness of their patients. And so indeed, there's a connection between coding and revenue. And as predicted by Congress and CMS, and I'll mention this in a minute, there is an incentive to code thoroughly. There is for some, those that are illegal or the like, an incentive to overcode intentionally. That should not happen. Those individuals should be pursued, maybe prosecuted, and maybe penalized. But we don't defend wrongful upcoding, not for a minute, we do not. It's a scourge and it's a blight on the system. We don't like to be accused of it, but nor do we defend it for a minute. So indeed, what they also got right is that the rules do need to be rewritten, made clearer. What is permissible coding? What is impermissible coding? The only sort of overriding arching principle that we would urge on them is that coding is best done, and there should be done, by engaged, integrated physician organizations. It's less well done when done remotely by health plans, not attached to the care process, not integrated into what doctors are doing day in and day out. So those are guidelines that we would recommend. Basically, we think that there ought to be tweaks, significant tweaks to HCC coding. And in that, Drs. Berwick and Gilfillan are absolutely correct. And then if there's an entirely better system, well, we would look at that. So we're not wedded to how we engage in this and how we report on the acuity of patients. We think that process ought to happen, but if there's a better one, we're all eyes and ears. Now, here's what they got wrong. And so bear with me. We've got a little long list here. Excuse me, slightly smaller print. So this whole subject of risk adjustment is critically important. So once upon a time, before there was risk adjustment in Medicare Plus Choice and then Medicare Advantage, there was an incentive automatically to avoid risks. So both health plans and physician groups, frankly, would not enter areas of high acuity, unmet social needs, inner cities, rural areas, et cetera, et cetera. There was and remains the long-standing story, true or not, I'm not really sure, that during Medicare Advantage enrollment, they had the enrollment desk, one or two flights up a couple set of stairs so that sick seniors could not, make it up the flight of stairs and register in Medicare Advantage. Now, whether that's true or not, as an anecdote, it does illustrate the point that without risk adjustment, here's where the critically important point, without risk adjustment, there's an incentive to dodge sick patients. With risk adjustment, there's all of a sudden an incentive to address sick patients, move into areas, vulnerable areas, and bring services to those patients, sometimes high acuity. Where there's acuity, where it's recorded, and where there's payment for it, that's potentially profitable for physician groups, irrespective of the humanity associated with it. And so risk adjustment is critically important in terms of addressing social disparity or health disparities and social equity issues and SDOH, social determinants of health. So point number one, we can't do anything really to threaten risk adjustment, and it appears they're prepared to do that by throwing the present system out and replacing it with something. So caveat number one, they may be totally wrong on that. Next, as I've already mentioned, so health equity and disparity are indeed the sort of the number one priority right now of the Biden administration. Of course, we welcome that. We clearly need to continue with the value movement, but addressing disparity issues, equity issues, social determination of health issues is completely necessary and appropriate. We're prepared to do that. And it can only really be done if there is risk adjustment and if there is actually coding for social issues. So if somebody's in a food desert, or there are no pharmacies within 20 miles, those factors impact the acuity of a population and the health of individuals. And so those factors should be considered when acuity is determined and payment is likewise determined. So that risk adjustment and coding is going to be necessary if we're going to basically accomplish this sort of number one priority of the Biden administration. Next thing that I think they're missing is the importance of primary care. So we learned, particularly through the pandemic, just how important primary care was and is. Without it, we're up a creek without a paddle. It is what is necessary to treat chronic disease. Chronic disease is what is bedeviling our healthcare system now. 80–90% of the spend is on patients, particularly seniors with multiple chronic diseases. And that is where we need primary care, and we need primary care redoubled now that it's presently threatened. And again, we really saw that vividly, unfortunately, during the pandemic, is fee-for-service basically, threatened primary care, whereas capitated systems did not. So what we learned is that primary care thrives in capitated models, and it suffers mightily in fee-for-service. And so to the extent that we stop the direct contracted model, which is based on capitation, to the extent that we remove capitation anywhere, we're going to be threatening primary care. We need these capitated programs, professional risk, global risk, and these other APMs. Fee-for-service platforms don't work very well at all with primary care. So let's not lose sight of that. Next, okay, we've already effectively acknowledged that revenue is tied to acuity, and therefore we know higher codes can do that. But that's not how my members make money. They make money managing the total cost of care. This is where the real incentives lie. Where there's a cap rate of this and the total cost of care for a population is something below that cap rate, there's a profit, and it comes from outreach, prevention, the kind of data analysis we've talked about, the stratification of populations, the creation of disease registries, knowing which patients are sick today, and via predictive modeling, knowing which patients will be sick tomorrow. So that's how you get to total cost of care, and that's how you genuinely make a profit. And that's what my members do. It isn't coding games. It's all the work we do and the work done by virtually all of you in this audience, I believe, to manage populations by knowing who they are, what they are, where they are, and what their needs are. Then we allocate resources in an intelligent way, lower cost, higher quality, achieve the triple aim. So that's an important, and I think they missed that. Next, eviscerating Medicare Advantage will damage the value movement. I say that not because I have this great love per se of any single program over another, but it just happens to be a fact that for my members and for groups all across the country, they're cutting their teeth in the value movement and learning how to be accountable for cost and quality through Medicare Advantage more than they are in any Medicaid program, more than they are, frankly, in the Medicare MSSP ACO program. This has been the training ground and the launch pad for value, referring to Medicare Advantage. To impair MA, eviscerate it perhaps, will damage the value movement. So it is a program we need to treat very cautiously and basically, I think, promote and protect if we're going to continue to advance the value movement. Next point that I think they misunderstood. There already is embedded in law. It's been, I think it was in the Balanced Budget Act once upon a time, but then it's been restated. And of course, implemented by CMS. There's a coding intensity adjustment used every year to address the potential that the intensity of the population in Medicare Advantage is higher or lower than it is in the benchmark population, which is traditional Medicare, right? CMS and Congress understood that when they enacted the coding intensity adjustment. And so they can adjust up or down as necessary. And as we know right now, they actually reduce the compensation on the theory that there's more coding reflecting more ostensible but not real intensity in the Medicare Advantage population. And there may be some truth to that, but what is also equally true is that in original Medicare, you have laxity in coding. So the program that gives rise to the benchmark by which Medicare Advantage payments are determined is based on a fee-for-service model where physicians need only submit a code or two simply to justify payment. It isn't to demonstrate the acuity of the population. So it's established and acknowledged through all of the policymakers and the cognoscenti that know about these issues that there's undercoding in traditional Medicare, which is the benchmark. So for there to be a gulf between the two is obvious and understood by Congress, and it's there already. The lever is there to adjust payment. And raising the question, do we need to do anything more than is presently in the law? Final point that I don't think they acknowledge fully is that seniors are voting with their feet. So approximately 28 million seniors now are in Medicare Advantage. Fully 42% of seniors in Medicare are in MA. I remember a few years ago when that was in the low 20s, it's at 42% now. Projections are that it'll be half of Medicare soon, and probably quite a bit more than that in the fairly near future. So why is that? These indeed are voters, but they're also the citizens that are buying healthcare services, whether it's out of pocket or the like, or they're having paid into the Social Security program. They're voting with their feet because they see more value. They see supplemental benefits, they see lower premiums, they see lower out-of-cost payments, and they see higher quality, frankly, because they see coordination of care. They know that there are multiple needs involving multiple specialists, need management. And that is what Medicare Advantage brings, typically through primary care physicians. So it's a better program for seniors. They know it, and they don't want it harmed or damaged. And so it's yet another reason, basically, to make small tweaks to the program to improve it, but not to throw it out. So there is a list of the things that I think they got wrong. I think to conclude, I have the semi-facetious title of Babies in Bathwater. We all recall the adage of, don't throw the baby out with the bathwater, which I think applies here. Because yes, indeed, we acknowledge that Hcc coding is imperfect. There aren't clear enough guidelines on who does it, where does it, when does it. Those should be created. But those are in the nature of tweaks. We don't halt the direct contracting program because of it. We don't eliminate Hcc coding because of it. We make tweaks commensurate with the size and nature of the problem. So that's basically my conclusion. I think that a point that I didn't mention, this issue of whether MA is paid more than traditional Medicare. Milliman published a paper just last week concluding that was not the case, and in fact, it was very much the opposite. So I fear that or I think that really the underpinnings of their arguments are not accurate. They are correct with Hcc coding. Let's fix that. Let's move on. There are, final word, much more important battles to be fought. I mean, there is a fee-for-service model we've got to eliminate wherever, whenever we can. That must be done. There are issues of consolidation that for some people are really important. There are issues as to the amount that's paid to primary care physician and how that's determined in the Medicare fee schedule that have not been addressed and are clearly imperfect and inaccurate. There's just so many more important battles to fight that my brothers, Don Berwick and Rick Gilfillan, I think need to get that right. We're working with them and talking with them, and we'll get back to you with see where we go. But we certainly don't want the value movement distracted or derailed because of it. And so with that, I think I will conclude, and hopefully that's grist for good conversations. Mark, you can fire questions at me if you have any or comments, and be happy to handle those as well. So thank you all. So I imagine that in the background, fingers are flying as we try and get Mark.
Yes,
there,
I am here, but I don't know. I'm going to ask our secret control room. Here we go. Hang on one second. I should appear.
I see you.
There we go. Okay, thank you. Anyway, and I've been listening attentively. Indeed, I've been champing at the bit a bit.
Good.
Brilliant presentation, Don, and I mean that. I think that you distilled for our audience so much. I'm going to review this again at my leisure because it was very dense in a good way. It was there. You had a lot of information and insight. I mean, I have to say it was fascinating to me. I don't know if there's no reason you would have yet, but I blogged about this because
I'm sorry, what about it?
I blogged.
Oh, blogged. Okay, good. Yeah.
And you can read my blog and tell me I'm full of nonsense. But actually, I basically said what you said in a foreshortened way. Yeah. I mean, obviously, I've admired Dr. Berwick and Dr. Gilfillan for many years.
Sure, as have I.
Yeah. I think they're amazing leaders.
Yeah.
I have to say, I was very, very, very taken aback by their blog. I thought, wow. So here's what I want to ask you. I think you explained this beautifully, but I just want to engage with you a bit about it. The single thing I think that most shocked me was the idea that they're kind of calling for the end of MA. And if not directly, then pretty much, implicitly calling for the end of what Medicare Advantage is now. And I wrestled with that in my mind for some time because I thought, well, I'm trying to understand where they're coming from. I do, but it also felt, if I may just say, somewhat ideological to me rather than reality based, right?
Yeah.
That essentially what they were saying, and I'm sure some will think that I'm condensing this down too far, but essentially they were saying that there's too much profit motive in healthcare.
Right.
Now, the thing about that is we all know that the US healthcare system is almost surreally complex, right?
Yeah.
For-profit and not-for-profit hospitals both have to make margins to
Yep.
survive. Technically, most physician practices and physician groups are technically for-profit in the tax sense, right? But that doesn't make them more money grubbing than anyone else in healthcare, right?
Right.
A lot of this is tax code based, right?
Mhm.
And in fact, one of the when I was reading their blog, what immediately came to mind actually was an interesting thing, which is many multi-hospital systems are being challenged by community advocates now as not providing enough charity care to validate their remaining non-tax paying, right? Not for profit in the legal sense. So, and everything in healthcare is jumbled to begin with. So I guess my bottom line issue was, wow, you're basically taking away, if their recommendations as stated in that two-part blog were to be like magically implemented, right? You're taking away a gigantic motivator for providers to be involved in value.
So I agree. I mean, this is really the corporate practice of medicine debate that we had for so long.
Yeah.
And as you all know, so this is really the question of, should profits from the delivery of care find their way out of the healthcare delivery system to Wall Street in the form of dividends to large corporations or even small corporations, right? And indeed, that's been debated forever. The actual corporate practice of medicine, I think 47 states now, frankly, allow it. Even California now, and I think Texas and one other, still have rules that sort of prohibit it, such you have to create these convoluted things. But it's the familiar debate. And though it's changed in its character a little bit now, and there is this talk about source of funding, private equity versus traditional banks versus mom and pop. Is it physician financed, et cetera, et cetera? So I think as you read between the lines, you basically see in their deck this kind of, tacit assertion that health plans are bad because they're not deliverers of care. They are, most all of them, not all, but most, by nature for profit with fiduciary duties to shareholders. So I think they're renewing the debate of who's involved in the delivery of healthcare and where the monies are going, particularly where the profits are going. That's between the lines, clear to me. They don't advocate for the elimination of Medicare Advantage, but you can readily tell that they think the health plans are principally the wrongdoers here. Though in their net, they include physician groups in a kind of a quasi, conspiracy with health plans through their percent of premium arrangements and so on that were equally bad, which, didn't, as I said, didn't feel good. But it also, think about this just for a moment. I mean, we're talking about, a quarter or a third of the physicians in the United States make money coding on Medicare Advantage. To posit that all of them are engaged in some macro conspiracy is pretty absurd. Are there wrongdoers? There are. But again, so where are they going with this, Don and Rick? And of course, I've kind of confined my comments, I think, in fairness, to the sort of four corners of their blogs. But you can see, an aversion to health plans. And, we also know that in public comments, I think both of them at one time or another have said that they are advocates of a single payer system. So I think that's definitely true with Dr. Berwick. I think he was an
Yeah.
advisor to Bernie Sanders and so on, and he's gone on record and said, I think that or something like it. He's very insistent that the current incumbents are not going to get us where we need to go. And everything he says makes me think, and I think he wouldn't deny this, that he indeed is a single payer advocate. Rick O'Fallon may be near where Don is. I don't really know. So indeed, your observation's totally correct, Mark. And the whole deck and the blogs beg the question of, well, where really are you guys going with this?
Yeah. Well, and if I may add also, Don, the other thing in all of that, I think you and I are on the exact same page, or as a good friend of mine says, I agree with you violently. But the other thing that really struck me was Medicare Advantage is where so much of the innovation has taken place in the last several years. And if you cut that off, I feel like I sit in a very complex mind space around all this, because look at the MSSP. It's the largest Medicare ACO program, as we know. And people have shown, including your members, have shown great strides. But even so, it's still only a tiny, the savings is tiny relative to the overall program. I don't think anyone could deny that. And that's not to demean it. It's just not that big, right?
Yeah.
So Medicare Advantage is where so many care management and population health management innovations have emerged from.
Yeah.
And if we were to eliminate that or devastate it, what would happen to that? I think there has to be motivation for providers and for plans to get a little bit of something out of innovation work.
Yeah.
They don't have to become rich. They don't have to become, doctors don't need to become billionaires. That's not what people are saying. But if there's no motivation, and one of the great things about APG, if I may butter you up briefly, is that you and your colleagues are really leading the charge, and you say it so publicly, so I don't feel like I'm outing you or anything. We need to move towards a largely capitated system at some point, right? Or something that looks like capitation. And you've been leading the charge into value. Well, anything that would retard that, in my mind, is not a good thing.
Agreed.
We've got to, right? I thought you'd agree with that. Yeah.
Sure.
I thought you'd agree with that. Yeah. And so to me, as you said, I think you framed this absolutely beautifully. This internal debate. I understand ideologically where, Doctors Berwick and Gilfillan are coming from, but I also agree completely with you that there's some very serious blind spots there. We just have to keep the value train moving. Anything that would slow it is not good right now. I was going to ask you if you had a chance to peek at the white paper that Administrator Chiquita Brooks-LaSure and CMMI Director Liz Fowler produced.
I did. This is now perhaps a month old, but it was their white paper about their work on the strategic plan, which now has come out. But I've not read. It's quite lengthy, but the white paper I did read. It's a month or so old. Yes.
Right. The thing that I really liked about it is it's very directional, right? They're saying we're going to focus on health equity, access to care. We're going to focus on doing better by providers, essentially. Now, the proof will be in the pudding.
Yeah.
We all know that. They can say we're going to be super nice, but we'll see what happens. But one of the things I like about that is in that white paper and in the webinar they emphasized to the press last week that they're really going to look carefully at all the models not only to make sure that they're returning value to CMS and therefore the taxpayers, but also so essentially that they will do better by the providers. They will try to create and evolve forward benchmarks that make sense. They said numerous times in this hour-long webinar, we're listening to you providers. I mean, they directly said this. So I hope that that comes together well. I mean, we all need for it to come together well. Do you have any thoughts on that?
Plenty of thoughts. So I definitely read that paper, and I know about their strategic plan. So interesting. I guess priority number one is health equity issues, also known as disparities in social determinants of health. And of course, completely agree that we should be addressing those issues, those shortcomings. Completely think and agree that the best horse for riding that right now is Medicare Advantage. I mean, Medicare Advantage already has supplemental benefits. So a lot of my members are already dealing with nutritional insufficiency and transportation and housing and on and on and on. And so whether we like health plans or not, we must reluctantly at least agree that that model as designed no question, is the best of available models at addressing these issues. So there is that. Next, the expansion of coverage or the expansion of benefits, which is probably the better way to talk about it, is worth discussing. So I think we should expand coverage, as in more people, those that are uninsured, where states, for example, didn't extend Medicaid. Somehow insurance is a good thing, and we should expand insurance to them when and where we can. The expansion of benefits is certainly a little bit of a different question. So we have right on the table right now, I mean, Congress is talking about it today. Manchin has sort of changed his mind on it. Health, vision, and dental benefits, should they be added to traditional Medicare at significant cost? And I can see why they would want to do that. Frankly, we support that because we're physicians and we think that dental, vision, and hearing is very important to our patients, but or provided that the cost of those services gets included in the benchmark such that Medicare Advantage isn't disadvantaged and doesn't effectively have to pay for that. Sounds like a technical detail, but so there is that. It brings me to the leaky boat metaphor that you may have heard me say as I repeat it every 6 hours, which is good to expand coverage. But remember, if you put more people in a boat that has leaks, it actually leaks faster. You have to deal with the leaks at either the same time or in advance. And the leaks right now are a fee-for-service system that is bad in manifold ways. Those are the leaks, and they have to be addressed. So you can't forego, you can't just expand coverage without fixing the leaks. And that means implementing a sensible value-based system. So we have watched with candidly now, concern and alarm at the slowness that this administration has embraced the value movement. I mean, where are we now? We're in October. It was almost 12 months ago that Biden was elected. And only now are we seeing strategic plans that call for the pursuit of value, but in undetermined ways. They say we believe in value, but stay tuned. You'll see what we do with the various programs in the future. But trust us, we believe in value. So there's a walk and a talk thing, and we're waiting with bated breaths. I'm being very honest with you now. We have nothing but admiration for Chiquita and Liz Fowler. We talk about them all the time. But above them, shooting straight, I think there are those that aren't sure that the value movement makes sense or not. And I even don't blame them on that. So many of the programs didn't deliver good results, the APMs. We saw that. Even the ACO program itself, while it's generated a savings for CMS the last 2 years, hooray, it did not in the preceding 8. I think I'm approximately right. And the numbers are small. And it's an important learning grounds that we support. I have a lot of members in the ACO program, but it is not the model for the future. It's still fee for service. And so you see, just as you see this, I'm rambling, but bear with me. Just as you see this sort of corporate practice of medicine issue in the minds of Berwick and Guilford. They don't like to see money going to health plans in Wall Street. You also see a bias in favor of the Medicare ACO program. And that we look at it and we go, do you see that as in-state, the destination, as it were, or just training grounds? We see it as training grounds. And they, I think, see it as destination. That too is a feature of their blogs. And so there again, we have a little difference of opinion. So I've talked all around it. We're just in this interesting moment where I think you've got actually a debate going on within the administration, and these very, very articulate, well-respected men are saying to Javier Becerra and others, no, stop this. Health plans are robbing the country. The money's flowing out to Wall Street. This is the problem. This is what we got to fix. And, you know, I'm all for fixing problems, but if their advocacy damages the movement, we can pause it for an hour. But if we pause it for 4 years, we got a problem. And that's what this deck is all about.
Yeah, absolutely. And I honestly, Don, I think your presentation was brilliant. I really do.
Well, thank you. I appreciate it.
Absolutely. And it's amazing how, as I mentioned, a friend of mine would say, I agree violently. I second everything you said. I think that, yeah.
Most observers do. Everybody recoiled in horror when they saw Berwick and Gilfillan's deck and then the blogs. I think that's probably why Alan Wheel published them. They're so controversial. Yeah. And then we had a hard time knowing how to respond to these revered gentlemen, right?
Yeah, you don't.
I mean, you don't want to be seen as disrespectful, but holy cow, don't you guys know what you're doing?
Yeah. I mean, it would be like if the Queen of England tripped on her skirt and fell down. You know, do you say anything, right? But no, I appreciate it very much, Don.
Yeah,
and
good.
I just want to say again, I absolutely love the fact that you're always willing to rush into the thick of battle in the ongoing healthcare policy debate. We need people who are as informed, enlightened, and mission-driven as you, because there will always be a cacophony of voices. But one of the things that you bring to the table that I admire tremendously is your knowledge and insight. You're not just blowing off steam. You actually have points to make. And I appreciate
I appreciate that. I guess I'm fooling you a little bit. I'm glad to do it. I mean, I'm in this ivory tower. I'm on the 16th floor downtown LA right now. I pay a lot of attention to these things, so I do know a bit of what I'm talking about. But now I'm not blowing smoke. Your constituents, your members that are in this audience right now, that are in the process of doing the informatics and the data mining and the artificial intelligence and so on, they're smarter than me times 10 on many of these issues. They probably smile as they hear me stumble and try and talk about HCC coding. They know it, you know, backwards and forwards. So anyway, your membership is critically important to this movement. So I thank you and I thank them.
Absolutely.
Yeah.
Well, this has been such a great discussion, Don. I think I'll just close by saying, you know, we need everyone. We need people who are crunching the data. We need people who are care managing. We need people who are developing policy, and we need people who are advocating for policy.
Yeah, I agree.
As we all work together, I'm definitely a glass half full person by temperament. I'm sure some of my friends think I'm surreally optimistic. What I will say in this case, I don't think I'm surreally optimistic on the complexities of the US healthcare system. But what I will say is, I feel good about this moment in one regard, and that is that many of the issues that we're calling out to be addressed are at least being discussed. And we are moving forward in the value movement. Your members are moving forward even as we speak. At this very moment, your people working in your member physician groups are managing care. They're bringing value. They're analyzing data. You know, they're doing all the things that we're asking the providers to do.
I'll add one to the list that I love, particularly so many of my new members. they're proliferating the model.
Yeah,
They're
exactly.
all over the eastern seaboard and in the middle swath of the country, opening clinics in capitated. I've got a couple handfuls of members that are doing that. There's a new breed out there that's doing what we want. They're bringing, risk-based capitated care to the country on the private side. So our private sector people are really helping us out, frankly.
Exactly.
So that's kind of that's recent years. And this is a good sign.
Absolutely. It's a good sign.
Yeah.
Thank you again for your
Okay.
wisdom and your engagement and the generosity of your time, Don.
My pleasure. Good. Stay healthy, everyone. Hope to see you again soon in person.
Absolutely. Thank you so much.
Okay, thanks, Mark.
And this concludes the session. Thank you to you and our audience.
Okay.